Assalamu alaikum. I'm Barda Rashid and my roll number is BP1650251. I'm from group number 10 morning and I will be presenting metabolic alkalosis. So in this slide, I've covered few important things regarding metabolic alkalosis. So in this condition, body experience extreme low level of hydrogen ions or high level of bicarbonate. So we know that when there is a low hydrogen ion or bicarbonate, if there is increased bicarbonate, so our body pH leads to elevated. Obviously, it is greater than in this condition. It is greater than 7.45, and we can see when there is we have a compensatory mechanism. Metabolic alkalosis leads to alveolar hypoventilation, which is a low respiration, because by keeping the arterial carbon dioxide, which is PaCO2, it will equilibrate the condition, and metabolic alkalosis and hypokalemia are highly related to each other. So we have two classes of metabolic alkalosis. One is saline responsive, and number two is saline resistant. So saline responsive, we can say it is more common because there is a loss of chloride rich or bicarbonate poor fluid, which is related from the to the vomiting, nasal gas suction, diuretic therapy, and cystic fibrosis. While in saline resistant, it could be due to the hypokalemia and excessive mineralocorticoid therapy, and we can say it is the rare one. These are the rare causes, and they can be distinguished based on the assessment of the patient's volume status, blood pressure, and urine chloride concentration. So we know that when there is a potassium and chloride depletion, so there is a confusion, lethargy, headache, delirium, tetany, seizure. So these are the symptoms which are included in metabolic alkalosis. So, what are the causes of metabolic alkalosis? Number one is diuretic induced. It is the most important one because when we take diuretic, there is an increased excretion of sodium chloride and water, which leads to the stimulation of aldosterone. And when there is increased aldosterone production, so the renin-angiotensin system is being activated, and when there's activation of this, so adrenal cortex which are present on kidney release all aldosterone, and when there is increased aldosterone, so it will lead increased sodium and reabsorption, and increases hydrogen and potassium excretion. So hydrogen, we know that when there is a increased hydrogen excretion and increased potassium, so obviously there is a condition, ultimately it could lead to alkalosis, and obviously there would be a hypokalemia, and it is the most important cause, which is the second one, which is the swollen depletion, because we know that vomiting and nasal suction, they are highly rich in gastric acid and chloride. So when there is excessive vomiting and nasal suction, so it could also lead to metabolic losses. And other causes related to this condition is renal acid loss and bicarbonate excess. So here's a case study in which there is a 50-kilogram woman who is 60-year-old, was admitted to the hospital 4 days ago with peripheral edema and pulmonary congestion consistent with the congestive heart failure exacerbation. She has been treated aggressively with furosemide, which is the diuretic, 80 to 120 milligram IV daily. And obviously, when there's a diuretic, so urine output will increase. Here we can see the generated 3 liter of urine output each day. Her chest radiograph findings and peripheral edema now show considerable improvement because furosemide is given to improve fluid retention, and obviously it is also given to treat congestive heart failure. So, however, she now complains of dizziness when she gets out of bed to go to the bathroom, and physical examination reveals tachycardia, muscle weakness, and her ECG shows flattened T waves and U waves. We can see these are the laboratory findings. What are the laboratory findings here? Serum sodium 138 milliequivalent per liter, potassium 2.5 milliequivalent per liter, chloride 92 milliequivalent per liter, creatinine 0.9 milligram per dl, BUN, which is blood urea nitrogen, is 28 milligram per DL. pH is 7.49. PaCO2 is 0.6 milligram mercury, and bicarbonate is 34 milliequivalent per liter, and urine chloride concentration is 60 milliequivalent per liter. So the question associated with case study is what acid-base disorder is present. So I have prepared soap notes. So in subjective, I have concluded all the basic necessary information. So in this, her age was 50 years. This weight is 50 kg. Gender was female, and chief complaint peripheral edema and pulmonary congestion consistent with the congestive heart failure exacerbation. And what was the current medication? Furosemide 80 to 120 milligram IV daily. Here I've concluded all the objectives, which include vitals and lab findings. Here's the vital, it is the heart rate 100 beats per minute, and these are the lab findings, which I have already explained in the last slide. Okay, so in this slide, um, in this slide is arterial blood test interpretation, which is known as ABG, and other important information. We know that our normal pH is 7.35, and in our case, the patient's pH is 7.49. So it is also indicating that there could be a chance of metabolic losses. And in this case, bicarbonate 34 milliequivalent per liter. However, the normal level is 22 to 26, and PaCO2 can be super elevated or normal. It could be both. And the normal PaCO2 level is 35 to 45. When we can see in our case, there is a flattened P waves and U waves. It could be due to electrolyte imbalance, and hypokalemic symptoms are tetany, tremors, muscle weakness, which we have already seen in our case. So these are indicating that patient is in the state of metabolic losses. So what is the assessment? According to the given information, we can conclude that obviously we have given the furosemide, which is the loop diuretic. It is to treat congestive heart failure. But as we have already covered, that there is a cause diuretic induced metabolic losses. So it is a clue to her acid base disorder, since because we know that there is a her potassium level is down, hypokalemia, it leads to dizziness, muscle weakness, arrhythmia, and increased serum bicarbonate. And there is a compensation. There's a compensation mechanism for metabolic losses, which was PaCO2. What is the intervention and plan? We have to stop diuretic, which is a furosemide, as soon as possible, because we have to treat the cause, and we know that it's a cause. And what could be given? We can give potassium chloride supplements, because we have to overcome the potassium depletion and decrease the severity of the metabolic losses. um, the other thing is we can give potassium sparing diuretic. We have to keep in mind that it's a potassium sparing diuretic, while the furosemide was loop diuretic. So these amiloride, trimetyrene, and spironolactone, these all are included in potassium sparing diuretic. And we can give potassium replacement with the supplements. The dose is 100 to 150 milliequivalent per day. It can be given either orally in divided dose or a constant IV infusion. So, for congestive heart failure patient, hepatic, and renally compromised patients, in patients with hepatic or renal failure or congestive heart failure, we have to give infusions of larger volume, because these electrolyte replacement, um, because we have to monitor closely for these complications. uh, um, so what is the treatment for those patients who are at risk and are responsive to sodium and potassium chloride therapy? We can treat it by acetazolamide. What is acetazolamide? It is a carbonic anhydrase which reduces the reabsorption of bicarbonate, resulting in increased excretion of sodium and bicarbonate. And we can also give a solution of 0.1 normal HCl in order to for those patients who require rapid correction of alkalemia, and dilute solution should be administered via central venous catheter in the superior vena cava to reduce the risk of extravasation and tissue damage, and the infusion rate should not exceed zero point 0.2 milliequivalent per kg per hour. Thank you.